it's dangerous. Now, we can all go along for a period of time and we don't need it, but at some point when we need it, it's better to get it sooner than later. Now, we have a tendency in our old health system to wait until you're the wreck of the Hespers. Okay, you can't have too much, don't have this, don't have that. Then, when you're at death's door, say, oh, put them in the ICU, call 911, run them through the ER, let's just give them everything, don't let them die. You go, I would rather invest in quality of life and alternatives to 911. For instance, we've done a lot of work in palliative care at home. What do you do during the last year of life to make it good? Because, it's still a time of great meaning, and if you're lucky enough to get notice, it's kind of good because you can really realize, okay, what's on my bucket list? Let's get it done. This is important. And 25% of the Medicare dollars spent in the last year of life. So it's a huge societal investment. But we found with giving people choices, meaning more than one discussion, more than handing them an advance directive, but having discussions more than once, having really good information from their physicians and nurse, having emotional support, people began to understand the nature of the choices they're making about the kinds of care they want, and they are able to make different decisions on their own. Not that the insurance companies withholding care, but I'm deciding, do I want to be at home with that dog walking me? Or do I want to be, so you have to decide, you have to weigh, what are the odds you can have a great cure, which you might, or that really there's some really disruptive interventions that are going to take away the pleasure of your time, and very slim odds that they'll be successful. Those kinds of decisions, we did random control trials in 3 states with Kaiser, found that we dropped the cost of care by 25% at the same time that we improved the quality of life, and the doctors and nurses felt really good about it because it was just a much more human dialogue. It was a much more thoughtful way to give care. It was much more whole person oriented. So focusing on the person, looking at all of these aspects, very, very important. So one of the things that we're working on are some of the opportunities that are embedded in the new health law. And I promise I won't talk too much longer. But I hope that you'll think about these, because I think, at least to me, I find them exciting because I think, how you look for kind of, if you have a flat tire, you need a jack and you need a lever so that even I can lift that car up because of the leverage. So we need small changes that have big effects, right? So palliative care, putting decision-making in it, creating an alternative 911, letting people have someone to call besides 911. Big, huge change in the quality of life, the experience, and the cost. So we're looking for those kinds of changes to move medicine from the presenting problem to the whole person. So one of them starts kind of late because, you can hear I'm very interested in prevention, early detection, all those kinds, keeping these problems at bay, staying good as we can, and we can stay quite good. But you have to also look for a business case for change. So one of the things in the new legislation is a very valuable thing in my mind. It looks at the fact that we have in our hospitals, when Medicare patients go home, 20% of them are readmitted to the hospital within 30 days. Now that's actually not appropriate. It's a failure in the system. And it doesn't actually mean that the hospital stay is too short, although it may in some cases. What it means is we push them off a cliff. Have you ever had that experience? You take someone home, you go, oh my God, well now what do we do? They can't really get around, and so which meds do they take? So hospitals now are on a measurement program, and one of the things we do now is we publish results that compare institutions, which is very good. It's sort of like going to Weight Watchers and getting weighed in. It drives business too, though, because you can see which hospitals have better results. So in 2012, any given hospital that has not got a decent rate relative to its neighbors in readmissions will have all of its Medicare reimbursement rate dropped by 2% and won't be paid for those readmissions. Oh boy, I can make change around that. They can't let that happen, and they are not good. They're not, the hospital people are great. I mean, I was one for 20 years, but they're not home people. So we need people who can be the bridge from the hospital to the home and help people connect to and communicate well with their physician. So we have a whole thing called care transitions. There's been a lot of research done. This is evidence-based, and it helps follow people from the hospital to the nursing home to home and helps them get stable and get safe. So that, to me, is a very exciting for two reasons. Of course, it's great we can drop the rate of readmissions now. How many of you would like a hospital stay? I thought so. So we can avoid that hospital stay. That's really good, right? And it drops the cost of care. So that's really good because America needs to save money. It does not need to spend money on bad experiences that are expensive. So, and it allows us to work with physicians the way they learn, which is they learn case by case. So now we're going to see a person in the hospital, then we're going to follow them and see them once in the home. We're going to take a snapshot of the environment. It's dark. It's got throw rugs that are a tripping hazard. There's no food there. Or the food is old because they were in the hospital. We think maybe nutrition is a big problem. What kind of meds are there? You go to the hospital, you already had medications. They don't want you to take those in the hospital. They give you new medications, and then they don't know what else you have. So they send you home with Coumadin, and you're taking 3 aspirins a day. Not so good. Or you have several problems because you're older and you have multiple comorbidities. So maybe you go to someone because you're not sleeping right, someone because you have pain, and someone because you have some kind of a muscle contracture. And they all give you similar meds. And suddenly, you look like what people think old is, which is really just bad health. You know, old age isn't really that bad. So medications have to be looked at live in the house and find out what's really there, especially because we have multiple doctors. It's an insured population, and no one pays the doctors to talk to each other. So finding those meds and letting the doctors know what people are really taking and helping people understand, and then helping them get an appointment with their physician so that they don't get in trouble and then call 911. So real duh factor changes, simple, basic. These are really important. And so that's going to allow us to take a snapshot and show physicians, patient by patient, the kinds of things that really ruin the medical investment that they're making. It will really help families to get people home safely and restabilize them and let them start to recover. So a very important and exciting change. Everyone won't get it, just people who are at high risk of readmission, but we think it's important. And then the other thing we're doing is people who have complex situations, they are going to be required in medicine now to have a health risk assessment annually that will lead to a care plan so that instead of waiting for the person to come in and saying, gee, I haven't seen Mary for 3 years, this says, okay, you can improve the way you're paid, you can improve the health results you get, but you have to comply with really looking at the whole person and dealing with it. So it's a big, big change. So that, again, will allow us to teach and demonstrate on a case-by-case basis. And the savings those will result allow us to have a way to pay for that. So, so the good news is I'm almost done. Yay! Oh, that wasn't it. That woke you up, right? Okay. The good news is we can change behavior. And we have evidence of that. We have hard science, random controlled trials, that people actually can change behaviors and get good results. The Stanford program shows not only do people find that useful, but They don't have to see the doctor as often. They don't go to the ER as often. They don't go to the hospital. They don't have as many hospital days. Just with that little 6-week class, they are able to engage in new behaviors that help them manage chronic illness. Really, manage is maybe not a good enough term. Beat it back, smack it around, get in charge of it, really get better results. So, of course then, much better quality of life. People who take these kinds of workshops report that they sleep better, they have a lot more energy, they're in a better mood, they have less pain, they just have a lot of things that get better that you'd think, oh, wow, how's this going to work? I'm starting to, have the, as a friend of mine used to say, after 50, it's just patch, patch, patch. Because people start to have aches and pains, they have knee problems, they have various things, but really, all those things you can do a lot about. And so it's very important. If you're going to age positively, which you are, then you have to do that. Now, that takes a village, and we notice that we're getting people out and about for these aspects. Did you know that gyms are getting older populations now? It's nice. People 55 and over, there's 500% more in gyms. And, of course, that doesn't count all the personal trainers that some people have, and the walking clubs and that famous dog. Don't forget the dog. Nice way to meet your neighbors, too. But there's an interesting study of some towns. Have you seen some of the stories about these towns that take on health as a whole? So I like to just kind of close on this Minnesota town, and it was one woman. Remember, we have to have a product champion, a change champion, somebody who just says, wow, this is so important, I'm going to get it done. She engaged the whole town. The restaurants changed their menus so they might still have fried chicken, but they had at least one healthy item on the menu. They got walking clubs. They did so many things to make their town healthier, and they walked 42,000 miles. They had, they started tracking their miles. First year they walked 38,000 miles, just tracking how much they were. Next year, 42,000 miles. They changed the way they ate. They talked about it. They got together about it. They got people out of their houses and hanging out or in each other's houses. So really important, I think, to think about, these new village models that are coming out, neighborhoods, associations, organizations, so that we all go, okay, we're going to live long, let's make it fabulous. We really want it to be great. So, and in the course of that, we can bring vision, we can bring powerful tools that are proven, build a platform together, many kinds of platforms customized to culture and individuals and communities, reduce pain, reduce illness, get people moving, and so that's my mission. That's not a project, that's a lifestyle. So that's my encore career, and thank you for your time.
The Institute for Social Innovation at Fielding Graduate University thanks June Simmons for her contribution to the 4th Annual International Conference of Positive Aging. This has been a presentation from the 4th Annual International Conference on Positive Aging, held in Los Angeles at the California Endowment Center for Nonprofit Management. The conference was hosted by the Institute for Social Innovation at Fielding Graduate University in Santa Barbara, California.